It can be challenging to tell a cold from bacterial sinusitis, from allergies, but there are simple frameworks that can make it easier to tell them apart, to know when antibiotics might actually help, and recognize when that sinus headache isn't from the sinuses at all. This is a solo episode from me, your friendly neighborhood otolaryngologist, and I impart to you what it's taken me a long time to figure out, because I wasn't taught it in medical school, and you may not have been either. Let's figure this out together. You're listening to Succeed in Medicine, the show for practicing physicians who want to master the parts of their career and life that med school never prepared us for. From interpersonal skills to career navigation to the essential information every physician needs. I'm Dr. Bradley Block, and in every episode, we bring you brass tacks advice and immediately applicable insights from world-class experts, so you can feel prepared wherever your MD takes you and build a life in medicine that's sustainable, rewarding, and actually worth all those years of sacrifice. You've spent years making careful decisions with lasting impact. When it comes to investing, the same principle applies. Lightstone Direct gives you access to institutional quality real estate investments with decades of proven experience behind them. Invest directly, no middlemen, and a $12 billion plus asset under management real estate firm in your corner. Remember, all investments involve risk. Please visit lightstonedirect.com for a full list of disclosures. Welcome back to the podcast. So I'm doing a solo episode. This is just going to be me talking to you about sinusitis, colds, allergies. How do we tell the difference? This is what I see in my office all the time. And you, the listeners, have been asking for more topics to be covered by specialists. You know, what are the things that the specialists want everybody to know about their specialty? And this is something that I encounter all the time. And what I learned in medical school wasn't necessarily correct. So I'm going to share my wisdom, my years of experience treating sinusitis with you. And first and foremost, it's important to understand that a bacterial sinus infection is a secondary infection in most situations, which means a virus is going to mess up the lining of your sinuses. It's going to make the lining thicker. It's going to make the mucus thicker. It's going to make it less efficient, which then allows bacteria to multiply in the sinuses, dig in, maybe form a biofilm, and now you've got your sinus infection, which means it has to start with a cold. Now, not every time, right? We have something called odontogenic sinusitis, where an infected tooth can cause maxillary sinusitis, right? Still, secondary infection. The tooth was infected first, right? And then it went on to infect the sinus. You can have someone that has chronic sinusitis. So this is someone who's had a lifelong history of sinusitis. Maybe they have sinus surgery. Their sinuses just don't work well to begin with. And they can spontaneously develop a sinus infection without a preceding cold. But for most people that have normal, viable sinus mucosa, what that mucosa is doing constantly is it's making mucus. The cilia then push that mucus into the natural sinus openings. It goes into the nose, it goes down the back of your throat, and you swallow it. Sounds familiar. Sounds like postnasal drip, right? Postnasal drip is physiologic and not pathologic. Your postnasal drip is always happening. It's constantly happening. It's usually not palpable. It's usually not noticeable, but there it is. So that's what happens in a healthy person. Now, when they get that virus, the mucosa stops working so well, and it allows the bacteria to then multiply. That is an opportunistic infection. It's been given an opportunity to develop. And so if you're trying to figure out if someone's got a cold or if they've got a sinus infection or a sinus headache, and we're going to be talking about that in a little bit, the most important question to ask is, was this person sick first? Did this person have a cold? Sore throat, stuffy runny nose, cough, right? The typical cold symptoms. And then what we typically see, classic is what we call a second sickness. So what happens is they start to improve, right? They get a cold, they get the sore throat, maybe a fever, they're starting to feel better, and then they start to feel worse, right? Oh, crap, I was feeling better, and then I started feeling worse. And then you might have those classic sinus symptoms of like discolored discharge, facial pressure, right, that they weren't having before, because now the virus is on its way out and the bacteria is on its way in. So that's how a classic sinus infection develops. Now, the recommendations are to not treat with an antibiotic for at least 10 days. And the reason is because most of the time, these things are self-limited. Often bacterial sinus infections can be self-limited. Not all of them need to be treated with antibiotics. So the teaching is give at least 10 days. Now, certainly there are exceptions to this. Like I've seen cases of orbital cellulitis. That's where a sinus infection gets through the ethmoid sinus into the orbit and causes an infection around the eye. And I've seen it happen where the patient was sick for like 2 days and then it went to the eye. So this didn't take 10 days to develop. So it doesn't mean that time is the best way to tell. Actually, time is the best way to tell because all the ways to tell are poor. So time is the best one we have, but it doesn't necessarily mean it has to take the bacteria a week and a half to develop. That's just classically. So then the question, well, if time isn't that accurate, then what is accurate? Is it facial pressure? Is it the color of the drainage? And the answer is no. You can have discolored drainage without having it be bacterial sinusitis. You can have facial pressure without it being sinusitis. And we'll talk about that in a moment, the facial pressure and the sinusitis. But back to the second sickness. So you'll typically see that bump in symptoms like, oh, I had a cold, I was starting to feel better, and now I'm feeling worse. That's classic. Sometimes it's not such a bump. It's more of like a plateau. There was no noticeable improvement and then worsening because it was all just pretty flat, right? Like the virus was leaving as the bacteria was coming in. So there wasn't, and it more just like, it's been a week and a half. I am not getting any better. But again, the recommendations are to wait that week and a half, wait that 10 days before you consider antibiotics, unless there's something else going on, right? Clearly orbital cellulitis that requires, in most cases, admission to the hospital, a consultation from an ophthalmologist and an otolaryngologist. You're going to CAT scan with contrast. You're going to make sure that there's not an orbital abscess that needs to be drained. That's an exception. But for most people that roll in and they're like, I have a cold, I'm sick, I need antibiotics, the week and a half is the recommendation. And that's the reason. One, because a lot of bacterial sinus infections are self-limited. And two, because how do you tell the difference between a virus and a bacteria? And really the time is, of all the bad ways, it's kind of like democracy, right? Democracy is the worst form of government except for the rest of them. Time is the worst way to tell except for the rest of the symptoms. So now let's talk about that facial pressure. So what I learned in medical school is that if you're trying to figure out if someone has a sinus infection, you push on their sinuses. And if they hurt, then it's more likely to be a sinus infection. Not true. Not true. Sometimes I'll teach med students, and what they've told me that they learn in their office hours with their mentors is that if you lean the patient forward and the facial pressure gets worse, that's sinusitis. Incorrect. Most of the time, that's migraines. Actually, large study showed 9 out of 10 times someone goes into primary care or an otolaryngologist's office when the main complaint is facial pain or pressure. It is 9 times out of 10, a primary headache, usually migraine. Facial migraines, sinus migraines are very common. So when you have the patient with the facial pressure, it's actually a negative indicator of sinusitis. It doesn't mean they don't have sinusitis. It just means it's less likely. And it's interesting because 50% of migraines can also cause a stuffy nose. So now you've got a patient coming in with facial pressure and a stuffy nose. That sounds like a sinus infection to me. Not necessarily. Very possibly a migraine. Another symptom that you can get in a migraine would be nausea, right? So now you've got nausea, and a lot of people are like, oh, it's my postnasal drip that always makes me nauseous, right? But like we discussed earlier, postnasal drip is normal. We actually secrete anywhere from 1 liter to 1.5 liters of mucus a day between our nose and our mouth, and we swallow it, right? Gross, but it's true. So if you have a cold, you're secreting a little more mucus, or allergies, or a sinus infection, right? How's that little more mucus going to make you nauseous? That's not a thing. Postnasal drip doesn't, I'm sure it can, but for the most part, it doesn't. So if the person has facial pressure, a stuffy nose, and nausea, it's actually more likely to be a migraine. And what you're really going to use to figure it out, was there some prodromal upper respiratory tract infection, right? Some virus that happened first. So if there's a prodrome, now I have patients that they will get a cold, and the cold is their migraine trigger. So some people, it's certain foods that they eat. Some people, it's stress. Some people, it's not getting enough sleep. And for some people, it's a cold. So they'll get a cold, and then it'll cause their sinus migraine. So that seems like a sinus infection. Now, that can take me quite a few visits to be able to untangle all that and figure out what's going on. But just to show you how tricky this can sometimes be, should that person get an antibiotic? I mean, certainly, because it really seems more typical for a sinus infection, but there certainly are exceptions out there. So secondary infection and facial pressure is more likely to be a migraine, especially if there's no prodromal cold. Dizziness is sometimes a symptom of those migraine patients as well. So people are like, oh, they have a sinus infection, it's affecting their ears, right? And that's making them dizzy. Actually, no, the inner ear is kind of a closed system. So if there's fluid in your middle ear, let's say from a cold, that doesn't make you dizzy. It might make you feel a little off, a little weird, but like dizziness from the inner ear, and we've covered this another episode a long time ago. If you want to go back to my vertigo episode, it was an excellent one. If you have any questions about dizziness, it clarifies a lot of stuff. So the inner ear, the semicircular canals, the membranous labyrinth, it's encased in bone. So if there's fluid on the outside, it doesn't really affect it. So a lot of people are like, well, it's affecting my ears and therefore I'm dizzy. And it's more likely to be a migraine, actually, in that situation, if it's associated with dizziness. And there's even something called a vertiginous migraine, but that where it actually gives you vertigo, which is a typical inner ear symptom. But again, that's more for the dizziness episode. Okay, so sinus infections, bacterial sinusitis, secondary infections. Okay, no reliable symptoms out there. That's been studied. Well, what if I have a cough and a stuffy nose? What if I have a fever and facial pressure? What if I have? And ultimately what it comes down to is we're not able to figure it out through the symptoms. It's really the whole picture that you have to use. And time is really the best one. Although, as I said, with like orbital cellulitis, there are exceptions and cases where they do happen faster. There are also fungal infections that you can get in the sinuses, but they are beyond the scope of this because we're not trying to tell the difference between a fungal sinusitis and a bacterial sinusitis. And we're just saying, like, how do you tell the difference between a cold and bacterial sinusitis? And then I wanted to let you all know about the frequency of sinus headaches that we see. So if someone wakes up one morning with sinus pressure, no prodromal cold, much more likely to be a sinus pain. And as I said, nasal congestion and facial pressure can happen in both sinusitis and migraines. So you really need that prodrome in the history to be able to differentiate the two. And even then, that isn't so accurate. And then the last thing is fatigue. You can get fatigue in a sinus infection. You can get fatigue in a migraine. So those three symptoms, facial pressure, stuffy nose, fatigue, could be either a sinus headache, a sinus migraine. Sorry, I'm going to use those terms interchangeable, or a sinus infection. Hard to tell the difference, right? And then we've got allergies. So, a cold versus bacterial sinusitis versus allergies. So allergies, stuffy runny nose, itchy, watery eyes, itchy throat. Those are the prototypical allergy symptoms. There needs to be some exposure, right? Sometimes people will wake up and they'll be like, I think it's allergies because I have an itchy throat. People can get an itchy throat with a cold. That can be one of the first symptoms. There needs to be some change in exposure. There needs to be some allergen, right? And so the question is, well, what is this person being exposed to now that's causing them to react that they weren't exposed to before? So if there's an acute onset in symptoms, the patient comes in and they're like, I've been feeling this for 3 days. I think it might be my allergies. Well, the question is, what were they exposed to 3 days ago that they're being exposed to now so they're continuing to have symptoms that's causing their allergies? Otherwise, it's not going to be allergies. There needs to be an allergen. And so if there's no new exposure, right, if it's end of April and they have tree allergy, or they don't know if they have tree allergy, but they suddenly have symptoms and there's this like yellow stuff all over the cars, right? That's the new exposure. If there's a new pet in the home, that's the new exposure. If they went to a friend's house and there was a pet exposure, right, and they're allergic to that particular pet, that's the new exposure. But if they've just suddenly got this onset of upper respiratory symptoms with no exposure, that tells me it's more likely to be the start of a cold and not an allergy. And people often use allergy meds to like dry things up, right? Antihistamines block the histaminergic response. But like if you have fluid in your middle ear, allergy medicine isn't going to dry it up. And even for allergy symptoms, dry it up, it doesn't really work so well. So let's go off on a tangent for a second and just talk about allergy medicine. The oral antihistamines are not great for stuffy runny nose. They can get a little bit at stuffy runny nose, but not very well. It's really the nose sprays that you're going to use. The nasal sprays are great for stuffy runny nose. The oral antihistamines are really better at the rest of the symptoms, right? Sneezing, itchy throat, itchy, watery eyes. But when you've got those patients with the super itchy, watery eyes, you're going to need eye drops. So the topical stuff is always going to be superior to the oral antihistamines, whether it's eye drops or nose drops. And then the nasal sprays, there's two different classes of nasal sprays. I am the nose doctor, right? So I'm going to tell you about the nasal sprays. So actually, I'm going to tell you about three different classes of nasal sprays. One is the nasal antihistamines, right? Astelin, Astepro, Patinase, called olopatadine. That one tastes the best of the three. So it's sometimes better tolerated. And those are topical. Those are fast acting. So they work almost immediately on contact. They're not as effective as the nasal steroids. So the nasal steroids are really the drug of choice, but the nasal steroids need to accumulate in your tissues over time. And so if you've got someone that has an allergy season that they know is coming, or chronic allergy symptoms with stuffy runny nose, the nasal steroids are really going to be your drug of choice because they're the most effective. But it can take a couple of weeks for them to really start working adequately. So you really need a good trial of them. They don't work for a viral upper respiratory tract infection. So if someone's got a cold and you're giving them nasal steroids, it's not going to help. There is a nose spray that will help with colds, though, and that's Atrovent, ipratropium. It's an anticholinergic. that will dry up an acutely runny nose from a cold. Not like gangbusters, right? It's not going to work amazingly, but it will certainly help. So actually for the cold symptoms, there's a couple things that I recommend for the nose. One of them is ipratropium. Actually, it's a prescription, so you can prescribe it for your patients if they're having a cold. There are some things you need to be wary of with things like glaucoma or enlarged prostate, but it can help. So if you're looking to give your patient some relief with a prescription, the ipratropium spray is a good one. Other things that you can do, and it'll work actually, since it's anticholinergic, it'll work for a runny nose and a cold. It doesn't work for a stuffy nose well, but it works for a runny nose. The thing that we typically give it for is something called vasomotor rhinitis, but you can use it for really any cause runny nose. Also pseudoephedrine, not phenylephrine. Pseudoephedrine, you have to get from the pharmacist, because in 2006, they said, this is how we're going to fix the meth problem. We're going to stop people from being able to buy large quantities of pseudoephedrine. So we're going to give it to the pharmacist, and they're going to have to take your license, and you're going to have to sign for it. And then the drug companies, I'm sure, were like, well, sales dropped 90%. What are we going to do? So they replaced it with phenylephrine. Phenylephrine has been in the news recently because it doesn't work. So don't even bother with the phenylephrine. Direct your patients to the pseudoephedrine, but just know, because it's pseudoephedrine, can increase your heart rate and blood pressure. So it can cause insomnia. Also, patients with any arrhythmias or hypertension, it's not necessarily a good idea. Or, don't necessarily take it before bed. Also, it can cause urinary retention in men with enlarged prostate. So be wary of that side effect as well. And then the last one, so that's going to Sudafed, Atrovent nasal spray. And the last one is oxymetazoline or Afrin. Yes, the one that you can get addicted to. It is great for a stuffy runny nose. It is fantastic. It is super effective, but it can also cause rhinitis medicamentosa. And it says right there on the bottle, don't use it for more than 3 days. So don't use it for more than 3 days. But if you've got a ridiculously stuffy nose from a cold or from allergies, all three of those sprays will work. But really the allergy, you want to use the allergy specific sprays. If you like this podcast episode, you're going to love the other shows over at the Doctor Podcast Network. For instance, Luxury Cruising. You know that moment? Sipping champagne, watching the sunset from your private balcony suite? Yeah, that's the magic of Luxury Cruising. Dr. Crystal Sinusitis takes you there on Luxury Cruising, explore the world in style. From the most opulent ships to insider secrets on upgrades, she's your guide to traveling first class at sea. If you're dreaming of your next escape, this is the podcast for you. Search Luxury Cruising and subscribe. Your suite awaits. What about for chronic sinusitis? Can you use nasal steroids for chronic sinusitis or acute sinusitis? So the recommendation from the American Academy of Otolaryngology is yes. But here's the thing, it doesn't get into the sinuses. Unless you've had sinus surgery and you're using it in like a bottle, like a neti pot or something, it's not actually going to get into the sinuses. So it might help a little bit with the symptoms of nasal congestion and runny nose, but it's not going to reverse the process of acute or chronic sinusitis, right? Except in those patients, sometimes we'll put budesonide in a bottle of saline and have our chronic sinusitis patients irrigate out their sinuses. But those are only the patients that have had sinus surgery where it actually gets into the sinuses. And so if you haven't had sinus surgery, the nasal steroids, even though it's on the list of recommendations, those can help your symptoms a little, but not very much. That's not the primary treatment for acute or chronic sinusitis. So then let's say you have diagnosed your patient with a sinus infection. Okay, now you've determined that they have acute sinusitis. What are you going to give them? First line of treatment is Augmentin, right? You can also give them a third generation cephalosporin. If that doesn't work, or if they've got a penicillin allergy, the next line of treatment is doxycycline. Staph is a less common cause of sinus infections, but if they do have staph, then the doxycycline would work for them too. And as we learned in med school, three most common causes of bacterial sinusitis, Haemophilus influenza, strep pneumonia, and Moraxella catarrhalis. Interestingly, the same bacteria that cause middle ear infections. Why is that? Well, the reason is the middle ear is effectively a sinus, right? If you think about it, your sinuses are these sinuses that come off of the nose, right? They've got a little opening that lead to a large cavity, right? That's what a sinus is, off of the nose. Well, that's what the middle ear is. The eustachian tube leads to the middle ear space off of the nasopharynx, which is the way back of the nose. So it's not a surprise that those three think that same thing. Middle ear infections are secondary infections, right? After a cold. And so sinus infections, secondary infections after a cold, extensions off of the nose, same bacteria. It all makes sense. Okay, so we've talked about how to tell the difference between a cold and a sinus infection, the fact that sinus infections are secondary infections, the fact that sinus migraines or sinus headaches are actually, when you have sinus pressure, are the most common cause of sinus pressure. Sinus headaches are the most common cause rather than a sinus infection, and pushing on their face does not help you determine if it's a sinus infection. Actually, I have a lot of patients that they complain that their face is swollen when they have a migraine. We don't see that in sinus infections, right? Unless they've got orbital cellulitis, right? Which is not that common. But people will complain that their face feels swollen when they have a sinus migraine, where we don't necessarily see that in sinus. But they're like, well, this is evidence that I have a sinus infection because my face is swollen. No, your sinuses are in bone. Your sinus infection is not escaping the bone and mucosa of your sinuses and making it into your facial muscles and facial skin to cause facial swelling. No, we don't really see that. Another common symptom that I want to talk about just very briefly is cough, because people will say, well, my postnasal drip is causing my cough. And something I see very commonly in my practice is really mild forms of asthma, even in adults. The patients, they've said they've had it their whole life, and it's viral induced asthma. So the typical story is, whenever I get sick, it goes to my chest. I tend to get chest colds. They've never been hospitalized for anything. It's never been anything serious. It always tends to be self-limited, but it can take a few weeks to go away. Sometimes even a few months to go away. It's just my winter cough. Like, a sinus infection can certainly make you cough, even in the absence of reactive airway disease, of asthma. Sinus infections can make you cough. So I'm not saying it's not sinusitis, but if you pick up on this pattern of patients that whenever they get sick, it tends to go to their chest. When they lie down, the cough is worse. And people often say, because it's postnasal drip, it's dripping down my throat. But you don't aspirating postnasal drip. The drip, it irritates the larynx. No, it's getting swallowed. If your Coca-Cola is not irritating your larynx and making you cough, then why is your mucus irritating your larynx and making you cough? No. They might have some element of asthma or reactive airway disease. So especially if there's been a pattern of this, you can try a trial of an inhaler. Just make sure you show them how to use it. Because even in the absence of wheezing, the presence of wheezing can rule in asthma, but the absence of wheezing doesn't rule out asthma. Right? And we often rely way too heavily on that particular part of the physical exam, where I think, just like they tell us in medical school, it's all in the history. So cough can be a common symptom of viral upper respiratory tract infections or sinusitis. And you got to find out from the history if this is a recurring pattern, because if it's a recurring pattern with the cough, there's a very good chance that it's just a very mild form of asthma, mild intermittent asthma, viral induced asthma, whatever you want to call it, where they just tend to cough a lot when they get sick, and they can do great on inhalers. But it's so mild that it's often been missed their whole life because they might not have even sought care for it, because it was more like a nuisance, but nothing serious, and it would always go away. So the myth that postnasal drip causes cough, I just want to dispel that. Postnasal drip doesn't cause cough. Like, when you get sick and you feel that postnasal drip, that's nasopharyngitis, right? Nasopharyngitis, the reason that we were swabbing felt like we were swabbing their brains at the outset of COVID was we were trying to get to the nasopharynx, because that's where viruses tend to settle. That's why you feel that postnasal drip. That's why you feel that sore throat and kind of that weird part of your throat. That's where the adenoids are, or used to be in some people. That's the nasopharynx. And that's why you feel that symptom of postnasal drip, because it's that nasopharynx, that way back of the nose, the way top of the throat, the junction of the two, which, by the way, is the whole reason that the specialty of ear, nose, and throat exists. It's the nasopharynx. It's the junction of the ear, because that's where the eustachian tube opens, and the throat, it's the top of the throat and the back of the nose. The nasopharynx is the whole reason that ear, nose, and throat is a specialty. So when you first get sick, you get this feeling. So is there anything that you can do about that symptom? No, not really. I guess you could use saline to try and wash some of that mucus away. It's not really going to do very much. That's one of those symptoms that we can't really do very much about. And it's going to evolve very quickly, right, into your stuffy runny nose, into your sore throat, into your cough as your viral upper respiratory tract infections evolve. And the mistake that a lot of people make is they think that the postnasal drip is what caused it. No, it's not cause and effect. It just starts out there before the viral particles go everywhere in your respiratory mucosa, affecting your nose, affecting your throat, maybe affecting your trachea and your bronchi or your lungs, making you cough. So it's not the postnasal drip that makes you cough. Postnasal drip gets swallowed. It's the virus that caused the postnasal drip and the rest of the symptoms that's also making you cough. And so there's some viruses that just make you cough, right? RSV, human metapneumovirus, COVID, flu. A lot of these are the viruses that we vaccinate against. The reason we vaccinate against them is because they are lower respiratory tract infections. And your lower respiratory tract, you really need to breathe. And so if that turns into pneumonia, that can be really dangerous. Adenovirus, enterovirus, rhinovirus, all these upper respiratory tract causing viruses, we tend not to vaccinate against because, yes, sinus infections suck and sinus infections can have complications, but, they don't lead to pneumonia unless the person has like a predisposing issue like COPD or asthma that causes their lower respiratory tract to be affected by these. But that's why we don't have vaccines for those, because they're not as dangerous. They're upper respiratory tract infections, not lower respiratory tract infections. There's one more thing that I want to talk about before we close out. And, we talked about viruses versus bacterial sinusitis versus sinus headaches. And then some people are like, my sinuses really bother me whenever I get allergies. Common thing that people say. We don't see allergies causing sinus infections. We don't. People with allergies might be more likely to get sinus infections because it just says something about how their respiratory mucosa works. It doesn't work so well because they've got some allergies. But the allergens don't affect the sinuses. And the reason that is because the sinus openings are valves. They're these tiny little openings, which is part of the problem, right? So for the allergen that's in the air, the pet dander, the dust, it goes into your nose. But for enough of it to get through these tiny sinus openings and then cause a reaction within the sinuses, it just doesn't happen. It causes nasal symptoms, but it's not going to cause sinus symptoms and it's not going to cause sinusitis. Now, we do have these, rare instances where someone will get something called a fungal ball. So a little bit of fungus makes it through the sinus opening and then sets up shop and multiplies until you got this big ball of fungus in the sinus, most commonly the maxillary sinus. And the only way to get it out is to actually do surgery. So we have to open up the sinus, make the sinus significantly larger, evacuate that fungal ball, wash out the sinus. Sometimes there can be a superimposed bacterial infection on there, but that's because a tiny little fungus made it through the valve opening of the sinus and set up shop. If you have an allergen, like a little bit of pet dander that happens to make it into, it's not enough to cause a reaction. So that's why allergies don't cause sinusitis. They cause the nasal mucosa to swell. But ultimately, when you get a sinus infection, it's not because the nasal mucosa is where the sinus opening is blocked. Even though we fix sinus infections, one of the ways by doing sinus surgery and unblocking the sinuses and opening them up. But there's a bunch of reasons behind that, like allowing better ventilation, allowing us to be able to get topical medicines in there, allow us to just wash everything out, right? Get rid of some of the chronically infected mucosa, particularly of the ethmoid sinuses. This is why allergies don't cause sinusitis, because allergens can't get into the sinuses, or not enough of them to cause enough of a problem. Because what sinusitis is ultimately dysfunction of the sinus mucosa. And if you block the sinus opening, this will cause another problem. You can get like an atretic sinus where the sinus actually starts to collapse because it can't ventilate. That's something called silent sinus syndrome. Happens in the maxillary sinus. And if it happens enough, it can actually cause the eye to fall a little bit because the roof of the maxillary sinus is the floor of the orbit. But that's a whole nother thing, right? Sinus infections happen because of dysfunction of the mucosa, not because of a blocked opening. And so this is why I'm not a big fan of balloon sinuplasty. Balloon sinuplasty is where you stick a wire into a sinus opening, thread a balloon over it, same principle as angioplasty, and then you inflate the balloon. The idea is you're going to allow the sinus to ventilate, you're going to allow things to drain more easily, but ultimately, chronic sinusitis is a problem of the mucosa, of the lining. And by changing the opening from 2 millimeters to 5 millimeters, right, I don't think you're actually doing that much. And unfortunately, some of my colleagues are actually marketing this balloon to the migraine patients. Right? Oh, you've got sinus pressure, especially when the weather changes, which, by the way, I don't even know what that term means because the weather's always changing, right? This morning it was cold. This afternoon it's hot. But I think when people say that, they typically mean like damp weather's coming in. And so 3 different patients know when the weather's changing. The migraine patients, people with arthritis, and people with like a lot of scars, right? They can feel it when the damp weather's coming. And so, they'll market. I've heard advertisements. Do your sinuses bother you when the weather changes, when you know it's going to rain? Those patients have a migraine. You're ballooning their sinuses to help their migraine. This is preposterous. The thing is, those patients tend to feel better. So the doctors that do it aren't necessarily doing something nefarious because their patients leave feeling better. The thing is, there was a white paper about this where they compared balloon to sham balloon for people with sinus headaches. And what they found was almost everyone got better, right? Because it was the placebo effect, which, as you can imagine from like a procedure, can be pretty powerful, right? But ultimately what you're doing is you're treating migraines by opening up the sinuses with the balloons. And so again, sinusitis is a mucosal problem. It happens from typically a viral infection that messes up the lining, allows the bacterial to multiply, and then you've got your bacterial sinusitis. Facial pressure, not a reliable symptom, more likely to be a migraine. And then allergies are a completely separate phenomenon. Each of them has the best way to treat that we discussed. And let me know if you all have any questions. And thank you for your time. Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means either you fell asleep or you really liked the episode. So please write us a 5-star review, take a screenshot, and email it to me so I can send you a quick guide on how to earn patient trust in 20 seconds or less. Email me at brad@physiciansguidetodoctoring.com and feel free to suggest a topic or guest. I take your requests seriously. The views expressed on this episode are those of the interviewer and the interviewee and do not represent the views of their employer or even their significant other. Even though the magic of podcasting makes it sound like I'm talking directly to you, this is not a doctor-patient relationship, and this is not medical advice, or financial advice, or legal advice, or really any advice. Thanks again for listening to Succeed in Medicine.